I mean, it's to collect the premiums and not pay out any of the charges. And so one of the ingenious ways of doing it was requiring pre-authorization. The insurance companies tried to insist that pre-authorization meant pre-authorization for visit, for an emergency visit. And we said, this is BS. You know, patients have to be able to come to the emergency whenever they feel like it. They shouldn't have to call somebody on the phone and get permission to go to an emergency. How can you possibly have pre-authorization for an emergency? You know, I mean, I'm sorry. I think I'm feeling like at about 2:45 tomorrow morning I'm going to have a heart attack. So I think I better call my insurance plan right now during 9 to 5 and get pre-authorization to go to the emergency department so they'll pay for my visit. And they said, well, I guess you're right. Pre-authorization means that once they get there, you have to call us and we'll tell you whether or not you can treat them or not. And if you don't get permission for them to be treated, then you eat the bill because we're not going to pay. And we decided that this did not fit. We needed to be able to see people and treat them. And the Bergeson bill addressed that question about pre-authorization, about what were people doing in the emergency department. Well, the answer was they were getting a medical opinion as to whether an emergency existed.
What was also contained in SB 1832 by Bergeson was the provision that the HMO couldn't deny the treatment based on the fact it wasn't an emergency, but had to apply the standard that what the person would have done, what the person reasonably should have done, given their situation. But it's the situation of that particular person rather than some generic prudent person. And I think that helps and makes it a better standard for the patient. And one of the difficulties is another feature of the Bergeson bill was a situation where a patient would come into the ER and they get stabilized. And so at that point, the HMOs understandably say, well, we want to, be part of the process since the emergency has ceased, that the patient's stable. HMOs, again, were abusing that because you'd call and there'd be no answer. So what do you do now? Well, then you're on your own, and then they determine later what should have happened, what you should have done. In the meantime, as an aside, because I can't resist it, is the HMOs took no responsibility in having backup panels or physicians there, contract physicians, coming in to take care of the patient and take over the care. So in the meantime, these patients are clogging up the ER. You got 10, 12, 15 patients that are waiting to get the call back from the HMO, and the place is falling apart. And so we had a provision in there that said that that if the HMO doesn't return the call within a set period of time, then they've deemed to give approval, and whatever care is given to the patient following stabilization is approved for payment.
SB 1832 garnered bipartisan support in the legislature, but still faced one last hurdle to becoming law: Governor Pete Wilson.
There's this wonderful woman who was the governor's legislative secretary who was on the insurance side, not the health side, named Glee Johnson. And as there were two extremely fortunate things that occurred. And the two very helpful things is it turns out she's the roommate for Marion Bergeson, which we had no idea at the start. This was a manna from heaven, because they're pals and everybody likes Marion, and she wants to help her roommate out, and so that was critical. And plus, her daughter is someone that's been to the ER and been taken care of successfully, so she has real life experience as to what it means to be in the emergency department. The bill was signed by the governor, and Glee Johnson had a big part of that, I'm sure, in the process.
So the Bergeson bill was very essential to how we practice medicine, because it established our turf, so to speak, that we were the experts in emergencies, where there wasn't going to be any second guessing by somebody at the other end of the line who was going to decide that this was an emergency. So the retrospectoscope disappeared, so to speak.
With California Emergency Department utilization at record levels amidst declining capacity and multi-billion-dollar state budget deficits, Cal-ACEP reached its fourth decade and beyond, facing the crisis of overcrowding and an assault on emergency care funding.
Every hospital is required to have a disaster plan for earthquakes, terrorist attacks, things that really, thankfully, occur very uncommonly. But there's no requirement that hospitals have a plan for the everyday disaster of emergency department crowding. Our legislation would require that every hospital develop a plan, and that based upon measurements of crowding in their emergency department, they would enact that plan to prevent bad patient outcomes. It's really all about keeping the patients safe, keeping the emergency departments functional, so that we are able to keep our promise to the community to be there for the patients whenever they're sick, whenever they're having emergencies, day, night, weekend, holiday, it doesn't matter.
We are overcrowded. You know, our patient wait times are going up and up, or our left without being seen rate is still really high, and we know that the patients who leave without being seen are not necessarily people who are not sick. In fact, they're just as sick as the people who get through the door.
But more importantly than the front door, the biggest contributor to emergency department crowding is hospital crowding. That is, admitted patients who have been seen in the ER, we've treated them, they're ready to be admitted to the hospital, but there's no bed upstairs. It's that back door where you can't get the patient upstairs into their hospital bed that backs up the emergency department, keeps us from seeing new patients who come in, walking in the waiting room, or even coming in by ambulance. It really paralyzes our ability to care for our patients in our communities.
Then the hospitals will have to figure out, okay, what is our way of measuring what's happening here, and what are we going to do when we are too crowded for patient safety? Does that mean we move patients upstairs? Does that mean we cancel elective surgeries? Does that mean we call in people from home? What are we going to do about it? Right now, most of them don't do anything.
And what I'm hopeful is that with this piece of legislation, we'll be able to get all hospitals to have crowding plans and actually use those crowding plans to get patients where they need to be, from the waiting room in to see a physician, from the emergency department hallway upstairs into a hospital bed. It's all about improving the healthcare delivery and the experience and care of patients.
In the spring of 2011, the state legislature proposed the elimination of the Maddie Emergency Medical Services Fund and its more than $100 million in support annually of indigent care in California, which had been created by SB 12, ACEP-sponsored legislation in the late 1980s.
I think what I'm most proud of is the accomplishment that we recently had in fighting off the attempt to slash the Maddie EMS funds.
The Budget Conference Committee has sort of run off with our Maddie fund, and there was no opportunity for discussion. There was no warning that this was what was going to happen.
And it helps fund the EMS system. It helps fund those consultants who will come in, the surgeons, the orthopedists, et cetera, anesthesiologists, and of course the emergency physicians and the hospitals.
And so the doctors who were on the on-call panel, who are there voluntarily, they don't necessarily have to be there, will take themselves off. And so now instead of having, a neurosurgeon at every couple of hospitals, maybe I've got one covering 6, which means when I have someone bleeding on their brain, it doesn't matter whether you have insurance or not. That doctor's just not available right now. And time is of the essence when that's your loved one and when you're that patient.
And, really, it was a proud moment for California ACEP because it was a grassroots response. Everybody became involved. From the leadership, the board, the executive director and staff, our lobbyists, our chapter members, of course. People came and made telephone calls. People came to our legislative leadership conference, showed up in white coats, and they walked down there to the offices of their legislators, and they said, no, we will not stand for this. This is too important. This really is going to impact our patients, and we were successful. Not only did they not trim the Maddie funds, but we reversed the entire cut. And that I was very proud of because it was a success, but it was a success that only happened because everybody at every level became involved, stood up, and spoke with one voice.
Our specialty, more than any other specialty, is really about taking care of people and being willing to be an advocate for a patient that no one else wants to take care of.
Been the sponsors of a bill that was passed and signed by the governor that instituted a new DNR forum in the state of California. I think it's given patients more control over how their very last days are lived. And so I'm proud of it. I'm proud that emergency medicine were the individuals who led the way in getting that passed. Happy 40th anniversary, Cal-ACEP.
Happy 40th anniversary, Cal-ACEP.
Happy anniversary, Cal-ACEP.
And just as was true in my own generation with the founders of emergency medicine, I'm quite sure that the people that are going into emergency medicine are doing it for all the right reasons. So I really think that they're going into it because they're interested in making the system work better and to do it in the most equitable way possible for themselves and their patients and their communities. And I have every reason to think that these residents are going to wind up being the people that make our system work better. Happy anniversary, Cal-ACEP.
Happy anniversary, Cal-ACEP.
Happy 40th anniversary, Cal-ACEP.
When I'm involved, I feel like I'm doing something, especially for the patients. You know, when I'm talking to a family member who, you know, doesn't have access to their managed care doctor, or they've been really having to fight with the system to get the care they need, I at least feel like, but I'm up here in Sacramento and I'm fighting for you. Happy anniversary, Cal-ACEP.
Happy 40th anniversary, Cal-ACEP.
Happy 40th anniversary. Looking forward to many more.
Happy anniversary, Cal-ACEP. 40 good years.
Happy 40th anniversary, Cal-ACEP.
I think the future of emergency medicine is very bright. There's no doubt that we face some challenges, but I have great confidence in California ACEP. We have great talent, we have great passion in this organization, and when we harness that talent, there's no stopping us.
Happy 40th anniversary, Cal-ACEP, and many more.
Happy anniversary, Cal-ACEP.
Happy 40th anniversary, Cal-ACEP.
Happy 40th anniversary, Cal-ACEP.
Cal-ACEP, happy 40th anniversary. I love the organization, I love the people. It's been probably one of the most satisfying parts of my entire life. Thank you for allowing me to be part of Cal-ACEP.
Happy anniversary, Cal-ACEP. You've done amazing work, and the best is yet to come.